Hello everyone. Today we are going to speak about antihypertensive agents or about medication used for treatment of high blood pressure. Uh, we are going to cover several topics, start from physiology, pathophysiology, and pharmacology, ending up with the clinical pharmacology. But the main focus will be on the treatment of pharmacology, how to treatment of hypertension, how to treat patients suffer from hypertension or high blood pressure. We need to take in consideration the patient case. For example, when you have patients suffer from the high blood pressure or hypertension and diabetes, high blood pressure and asthma, high blood pressure and arthritis. So we are going to have different approach according to the patient case. Another case, for example, high blood pressure and angina. What is the best medication for the patient with this different case or different scenario? So we need to be aware of the approach. What is the ideal approach, appropriate approach to your patient? Okay, start with the beginning here. According to the recent definition for the hypertension or high blood pressure, the definition of hypertension it changed with the according to the American Heart Association and American Cardiology guidelines. The recent guidelines changed from above 140 over 90, above or equal 140 over 90, to above or equal 130 over 80. So this considered like hypertension. Any maybe reading for blood pressure above 130 over 80 considered like hypertension. Okay, this is number one. Number two, they said, what happens if the patient exceed 120 and below 80? About here we are talking about systolic and diastolic. So they said if the systolic blood pressure 180, 120 and diastolic 80 or below, this is considered like elevated blood pressure, slightly elevated blood pressure. So what we have here now, we have another maybe category. The first category, hypertension, anything above or equal 130 over 80. The second one, elevated systolic blood pressure 120 and diastolic below 80. Okay. Hypertension occur when the systolic blood pressure exceed 120 or diastolic blood pressure exceed 80. The important issue here, we need to rely on several measurement of blood pressure. Okay, because we cannot only rely on one reading. Sometimes the patient come to the clinic nervous and scared from the clinic, from the medical results or anything or bad news for his or her health. Therefore, we need to measure blood pressure in different occasions. And we recommend the patient to take blood pressure at home and bring the reading to the clinic for discussion and more details. Okay, blood pressure, the dangers of blood pressure coming from the blood pressure has no symptoms. So roughly around maybe 80% or more of patient does not have symptoms. For this reason here, blood pressure considered like asymptomatic and considered like silent disease. Hypertension, if left untreated, so if the patient suffers from hypertension and without treatment and without take any process to control blood pressure, this will lead to the hypertension and stroke. And this is considered like main cause of death. So therefore, it's very important to treat hypertension. That's number one. Hypertension increased risk of the chronic kidney disease and heart failure. Okay. According to that, they said early diagnosis and proper treatment of hypertension markedly reduce the morbidity and mortality. So if you lift blood pressure without treatment, this will lead to the heart disease, stroke, kidney disease, and heart failure. They found if you diagnose blood pressure early and start treatment, this will lead to the decreased mortality and morbidity. Okay, according to the an adult 18 years and older blood pressure classification determined by the average 2 or more readings, this was very important for us. So this one, the category according to the American Heart Association recent guidelines, we consider the individual or the person like with normal blood pressure if the blood pressure blood pressure less than systolic blood pressure and diastolic. Here we have systolic, we have here diastolic blood pressure. If diastolic blood pressure less than 120 and diastolic blood pressure less than 80, this is normal. That's great. What about elevated? Elevated 120 to 129 for systolic and said diastolic less than 80. This is elevated blood pressure. Now we have the blood hypertension. So we have two stages for hypertension. Stage 1, we have stage 1 for hypertension. Okay, stage 1 for hypertension, 130, 139. You can see here we have range. Okay, 130, 39 for systolic or diastolic 80 to 89. So stage 1 hypertension, 130, 39 for systolic or 80, 89 for diastolic. Stage 2 hypertension equal or above 140 or equal or above 190. So if the patient comes with one of these readings high, we consider like stage 1 or 2, depends on the situation. Now we have case study for the patient, 64-year-old patient, suffer from recent heart attack, systolic blood pressure 149 and diastolic blood pressure 80. This will refer to which of the following type of blood pressure? What do you think? Which stage? Is it hypotension? Is it normal blood pressure, or is it elevated, stage 1 or stage 2? So if you look on diastolic only, so diastolic 80, okay, so I will go to the slide again. For 80, so he is in between this one here, between stage 1 and elevated. Okay, what about the diastolic blood pressure, 149? What do you think? This one belongs to which stage? Okay. Okay, 149 should be here. So stage 2 hypertension. So what is the correct answer? Okay, stage 2 hypertension. This one belongs to the stage 2 hypertension because we look on the or. When we have, they said equal 140 or more equal or more 90. So the patient here and the patient therefore considered like stage 2 hypertension. Okay, hypertension become more relevant with age. For instance, approximately they said according to the statistic, 70% of individual aged between 60 to 69 have hypertension. 70%. This is a maybe big number. So if you have 100 patients, 100 individuals between age 60 to 69, they found 70 individuals suffer from hypertension. 70%. Okay. What is next? They said if the hypertension persists without treatment. Okay, persisting arterial hypertension adversely affect blood vessels. Okay, we have blood vessels everywhere. Blood vessel in the kidney, blood vessel in the brain, in the heart, in the eye, and this hypertension affect maybe adversely or negatively the kidney, the heart, the brain, and this will lead to the renal failure, coronary disease, heart failure, stroke, and dementia. So all these consider like complications. So if you left this disease without treatment, this is a complication of hypertension. So complication of hypertension could be affect the vital organs such as kidney, heart, brain. So therefore, successful pharmacological reduction of hypertension associated with the decrease or prevent vascular damage. So we have vascular damage here, and the treatment will be reduce or prevent vascular damage, and therefore the end result will be decreased morbidity and mortality. Okay, so as we discussed in the beginning, hypertension considered like silent disease, no symptom, asymptomatic. Okay, sometimes the patient come to the clinic suffer from headache, fatigue, or dizziness. And normally we detect blood pressure during routine screening, During the clinical visit, the healthcare provider measured the blood pressure. They found the blood pressure high, or another issue, the patient starts suffering from complication. So the patient has high blood pressure for a long time, and he ignored the blood pressure. The result will the patient will start suffering from complication of hypertension. Okay, now moving to the etiology, the causes of hypertension. A lot of questions may be built on this slide. What is the causes of hypertension? They said we have two main categories for the etiology of hypertension. 90% unknown. We call this one essential primary unknown hypertension. We don't know the cause. We don't have identifiable causes for the hypertension here. Secondary hypertension, 10%. So when you have patients come to the clinic, let me say we have 100 patients visit the clinic, they said 90% of these patients come in with suffer from essential hypertension. Okay, 10% secondary, that means this patient could be cured from hypertension. We are going to discuss that later on. Okay. Family history, hypertension, increased likelihood of individual developing condition. If you have someone in the family like siblings or like parents or like first degree relatives, if they have a history of hypertension, this increased risk of hypertension. Prevalence of hypertension increases with age. Okay, with the age 55 and above. This one for female, and for male, according to the risk factors, 45 for male and above. So above and above. For female, above more than 55. For male, more than 45. Okay, increasing with age. And decrease level of education, decrease level or decrease income. So our income associated with the increased blood pressure. Okay, a study found that non-Hispanic black people, African American people, exhibit higher incidence of hypertension. Comparing with the non-Hispanic Hispanic whites, non-Hispanic white and Hispanic white. So the African American or black people exhibit more higher incidence of hypertension comparing with the white Hispanic or non-Hispanic white. Okay, moving to the next, what they found there. Also, patients suffer from diabetes, obesity, disability, more susceptible to the hypertension. Okay, so when you have history of diabetes or obesity or disability, the risk of hypertension will be more compared with the normal patient. Environmental factors could include stressful lifestyle, high intake of sodium. Therefore, we recommend to restrict sodium. Smoking, another risk factors. So we have risk factors here. Therefore, before we start treat hypertension, look on the environmental risk factors. Reduce the stress lifestyle, reduce salt intake, stop smoking. All these could help to control blood pressure number. Okay, so we discussed that 90%. We're moving to the 10%. What happened to the 10%? The secondary hypertension. 10%, we have several causes. We tried to maybe simplify the issue. I'm going to speak about one or two from each column here. The hypertension could be as a result of renal disease. If we have any renal disease in parenchymal tissues or in the renovascular tissue, in the blood vessels. So what happened here? The most important one, diabetic nephropathy. Okay, what else? Polycystic kidney disease, stenosis of the renal arteries. So all these considered like risk factors for the hypertension. Diabetic nephropathy, polycystic kidney disease, stenosis of renal artery. These will lead to, all these will lead to activate system called renin, angiotensin, aldosterone system, RAS. And this will lead to the maybe several actions. We are going to discuss it later on in the slide. Okay, so renal disease, we discussed several causes: diabetes, polycystic kidney disease, stenosis of renal artery. Endocrine causes here, primary aldosteronism, pheochromocytoma, Cushing disease. This is the most common. We have some rare. For the most common, primary aldosteronism, for when you talk about primary aldosteronism here, what we have here, aldosterone produced from the adrenal cortex. Okay, and if the patient suffers from aldosteronism, hypersecretion of aldosteronism, so the aldosterone will be high. So aldosterone will be high. So what happened there if the aldosterone high? The result will be sodium and water retention. This is number one. Number two, retention. Number two, increase excretion of potassium, urine excretion. So what we have here, the patient start retain sodium and water, and the result will be increase blood volume. Increased blood volume will affect cardiac output. Cardiac output will increase blood pressure. Why cardiac output increase blood pressure? Okay, because if you go to the equation, we have equation, blood pressure is equal cardiac output multiplied by peripheral vascular resistance. So cardiac output mainly related to the blood volume. So if the blood volume increased, the cardiac output will increase. If the cardiac output increases, the blood pressure will increase. So you are with me now on the same page, is that correct? Okay. So as you can see here, we discuss aldosterone. Maybe we can discuss also the pheochromocytoma. Pheochromocytoma, we already familiar with this name. Pheochromocytoma may be defined as a tumor in the adrenal adrenal medulla. Okay, adrenal medulla. So adrenal medulla responsible for secretion of epinephrine, and with a less amount of norepinephrine. Okay, so secretion, tumor. When you have a tumor, that means we have more epinephrine, and epinephrine will be released to the circulation. Norepinephrine will stimulate alpha and beta receptor. Okay, this will lead to the increased blood pressure. I'm going to discuss that later on. So pheochromocytoma. Cushing syndrome associated with the increased level of cortisol, and this will lead to the increased blood pressure through the retention of sodium and water. We have another maybe rare causes for the hypertension. Rare causes for hypertension could be acromegaly, could be the primary hyperparathyroidism and the thyroid disorder. So acromegaly, this is a case associated with increased level of growth hormone and from the anterior pituitary. Hyperparathyroidism, we talk about parathyroidism hormones. Okay, and thyroid disorder, we are speaking about the thyroxine level will be high, increased level of secretion of thyroxine. So all these factors, but this one considered rare, but this one is maybe considered popular endocrine disorder. Okay, moving to the The other risk factor could be vascular disorder such as coarctation of the aorta or vasculitis, obstructive sleep apnea, polycystic ovary syndrome, preeclampsia, drug-induced hypertension. Preeclampsia is the case associated with during pregnancy, especially third trimester, and the patient suffers from hypertension, proteinuria, and edema. This is the case of hypertension. The final one, maybe the last maybe point here, very important point, we have medication may induce hypertension. We have drug-induced hypertension. This is a very important topic. Therefore, when you have patient, you have to take the drug history from your patient. Does the patient take any medication? And this medication may cause hypertension. Okay. Therefore, I will have to focus on the drug-induced hypertension for the pharmacological purposes. As you can see here, we have amphetamine, we have cortisone, we have calcineurin inhibitor, decongestant, ergot, erythropoietin, estrogen and oral contraceptive, NSAID, testosterone, and some antidepressant medication. So amphetamine and methylphenidate, one of these important medication. These medication increase release of norepinephrine from the neuron, and we know the consequences. When you have epinephrine high, the result will be vasoconstriction and stimulate the heart. Okay. Next we have cortisone. Cortisone related to the aldosterone effect and retain sodium and water and blood volume increase. Calcineurin inhibitors such as cyclosporin, tacrolimus, and we discussed that with the medication used for asthma, or not asthma, medication used for the dermatitis and psoriasis. Decongestant, this is very important medication because available popular and OTC, no need for prescription, such as pseudoephedrine and ocular phenylephrine. Someone may ask, is the ocular eye drops cause hypertension? Yes, because some of these eye drops will arrive to the circulation and stimulate hypertension. Ergot, this medication used for treatment of migraine and may cause or may exacerbate of hypertension. Erythropoietin and darbepoetin, this medication used for treatment of anemia. Estrogen and oral contraceptive. If someone asks about how the NSAID may increase blood pressure, so NSAID inhibit enzyme called cyclooxygenase. Okay, this enzyme responsible for formation of prostaglandin, so inhibit formation of prostaglandin. Okay, this will lead to prostaglandin. So inhibit the enzyme, inhibit prostaglandin. They found, okay, in physiological function, in physiological case, okay, prostaglandin, we need prostaglandin for the kidneys because prostaglandin enhance renal blood flow. That's great. Cause vasodilation. Okay, vasodilation, prostaglandin. When you prescribe NSAID to your patient, the result will be inhibit this enzyme, decrease prostaglandin. What happened? Okay, the result will be decrease renal blood flow, and this will activate renin, angiotensin, aldosterone system. Okay, angiotensin 2 will be elevated and aldosterone will be secreted, and the result will be vasoconstriction and sodium plus water retention. and the end result will be increased blood pressure. So we explained briefly about what happened with the NSAID, about these consequences here, but it's very important steps for the situation. Now moving to the secondary to 10%, we have some, for example, excessive amount of food substances, sodium, ethanol, licoric. All these medications may cause hypertension. So we recommend patients to avoid these food substances, sodium, ethanol, and licoric. What about street drugs and other products? Cocaine, methamphetamine, ephedra, mahawang, ecstasy, anabolic steroid, ergot, herbal medications, St. John's worts. All these medications cause elevate blood pressure. So we talk, for example, if you speak about cocaine, okay, cocaine inhibit reuptake of norepinephrine from the presynaptic neurons, and this will lead to the increased availability of epinephrine in the neuron and increase, or when you have increased availability, that means able to bind more to the adrenergic receptor with the epinephrine and exacerbate the symptoms. So we already covered all these material here for the cocaine. Okay, so for this reason here, we are going to speak about what mechanism do you have in our body to control blood pressure. Do you have a mechanism for controlling blood pressure? Okay, so speaking about how the blood pressure will be controlled in our body system, so the topic now is like a mechanism for controlling blood pressure. Here we are talking about a compensatory mechanism. So our body manage blood pressure by providing enough blood flow to the organ and tissue without harming blood vessels. So we need blood pressure. We need the blood pressure to fight the blood to the organs and tissue. But the situation when you have hypertension, the hypertension will damage, will cause injury to the tissue and organs. So blood pressure depends on the heart pump and cardiac output and resistance in the blood vessels. Peripheral, we call this one peripheral. This is the abbreviation for peripheral vascular resistance. And we have cardiac output. And you know that from the equation already discussed. Blood pressure is equation. Blood pressure is equation between cardiac output multiplied by peripheral vascular resistance. So this is the equation here. Anything change in the cardiac output or peripheral resistance will lead to the change in the blood pressure. So cardiac output and peripheral resistance controlled mainly by two overlapping mechanisms. This is the important topic and concept in hypertension. We have two mechanisms, two overlap mechanisms, and this is a baroreflex and the number one baroreflex and renin angiotensin aldosterone system. And you can see here we have renin angiotensin aldosterone system stand for RAS. Then we have baroreflex. This is work on the sympathetic nervous system. So medication that lower blood pressure normally or usually work by reducing cardiac output or reducing blood or reducing relaxation of blood vessels. Okay, so any medication intended to lower blood pressure could lower cardiac output or peripheral vascular resistance. Therefore, we start looking which medication can cause decreased cardiac output, which medication can cause decreased peripheral vascular resistance. We are going to discuss it in the slide later on. Okay, compensatory mechanism number one, we have baroreflex. and this baroreflex mainly affects sympathetic system. Here we are talking about nervous system, sympathetic nervous system, sympathetic nervous system. Okay, so baroreflex act by changing in the activity of sympathetic system and parasympathetic system. So we have two systems there. When you have baroreflex will be maybe activated or inhibited. Okay, so what they found there, I will maybe summarize there. When you have decreased blood pressure, this will stimulate the baroreflex by stimulating sympathetic system and inhibit parasympathetic system. So this is a compensatory mechanism: stimulate sympathetic, inhibit parasympathetic. Okay, baroreflexes are responsible for rapid regulation of blood pressure. Any change in the blood pressure, this system will be activated. Decrease in blood pressure cause pressure sensitive neurons, baroreflex in the aortic arc and carotid artery, carotid stenosis, to send impulses, neuroimpulses. So we have now neuroimpulses send it to the cardiovascular center in the brain, or in the spinal cord, in the central nervous system. Okay, we have impulses, and this impulse stimulate cardiovascular center in the spinal cord, and the result will be increased sympathetic output and decrease parasympathetic output. So this is an important concept for the baroreceptors. Baroreceptor, decreased blood pressure will activate sympathetic system and inhibits parasympathetic system. So the end result will be vasoconstriction and increased cardiac output. Okay, therefore these change result in compensatory increase in blood pressure. Okay, another mechanism, renin angiotensin aldosterone system. We call this one RAS. The kidney provide long-term control. So I will go back to the slide here. So the one responsible for rapid regulation will be the baroreflex, and will be the sympathetic nervous system responsible for rapid regulation of blood pressure. Moving to the renin angiotensin system, this we are talking about the kidney here. Okay, and this one responsible for long-term control of blood pressure. So we need underline the kidney provide long-term control of blood pressure by altering blood volume. We have baroreceptor in the kidneys, responds to the reduced arterial pressure, and to the sympathetic system B1 receptor, releasing enzyme called renin. So this enzyme very important. The kidney produce enzyme called renin. Renin responsible for converting. Renin is responsible for converting angiotensinogen to angiotensin 1, and angiotensin 1 will be converted to the angiotensin 2. Angiotensin 2 under the effect of angiotensin converting enzyme. So we are going to have it in the slide. We have renin. Renin convert angiotensinogen to the angiotensin 1, and angiotensin 1 will be converted to the angiotensin 2 under the effect of angiotensin converting enzyme. Okay, what else we have there? Okay, also the angiotensin 2 responsible for secretion of aldosterone secretion. So angiotensin 2 stimulate aldosterone secretion, will lead to the increased sodium and water reabsorption and increased blood volume, which result in further increase in blood pressure. Okay, now we have this slide here talking about the compensatory mechanism of hypertension. When the patient, healthy subject or individual patient, suffer from decreasing in blood pressure, so the blood pressure compensatory mechanism here. So when the patient suffer from decreased hypertension, hypotension, so our system will be activated. Baroreceptor system will be activated. Baroreceptor will be activated. This baroreceptor available in aortic arc, in carotid sinuses and in the kidneys. We have to follow this system and to know the situation. Okay, the next slide we are going to discuss the blood pressure compensatory mechanism. Okay, so as you can see in this slide, we have the two main mechanisms controlling blood pressure. The first mechanism will be, I will say this one, autonomic nervous system. So when the blood pressure decreased, the baroreceptor will be activated. Baroreceptor available in the aortic arc, carotid sinuses, and in the kidneys. So we have too many places. Okay, so speaking about the baroreceptor in the aortic arc and carotid sinuses, this will lead to the activate sympathetic system and decrease parasympathetic system. Okay, activating sympathetic system, you remember that from the autonomic nervous system we have two main receptors there. It will be activated. We have beta-1 receptor, which is mainly available in the heart, and we have alpha-1 receptor that mainly available in the blood vessels. So what happened there? If you activate beta-1 receptor in the heart, this one will lead to increased cardiac output and contractility. Okay, if you increase cardiac output, the result will be increased blood pressure. Okay, activate alpha-1 receptor in the VSMC, stand for vascular smooth muscle cells. So if you activate alpha-1 receptor, alpha-1 adrenergic receptor in the smooth muscle cells, okay, the result will be increased peripheral resistance, and this will lead to the increased blood pressure. So this one, the compensatory mechanism. They said we have another things also here we need you to remember. Beta-1 receptor not only available in the heart, but they found beta-1 receptor available in the kidneys. And when beta-1 activated in the kidney, this will lead to the release of renin. So the renin, we know that renin is very important. Renin is very important for the renin, angiotensin, aldosterone system. Okay, so if the renin activated, what happened there? So the renin will lead to the formation of angiotensin 2. Angiotensin 2 also responsible for increased secretion of aldosterone from the adrenal cortex. Okay, so speaking about angiotensin considered like most potent agent to induce vasoconstriction. And this will lead to the increased peripheral resistance. Okay, so stimulate the blood vessels and increase peripheral resistance. Aldosterone, increased release of angiotensin 2, also increased release of aldosterone. Okay, aldosterone, the main action of aldosterone, retain water and sodium. Okay, retaining water and sodium, this will increase blood flow. Increase blood flow, this will lead to the increased cardiac output. If you move with this arrow here, increasing cardiac output will lead to the increased blood pressure. So you can see the cascade here on this graph. All this information here is very important for us. Okay, so we discussed the sympathetic system. Now we are moving to the overlap mechanism in the kidneys. So when the blood pressure decreases, two things will be activated at the kidney level. Number one, baroreceptor in the kidney will be activated, and this will lead to the release of renin. Okay, decreased blood pressure means decreased blood flow to the kidneys. This will lead to decreased glomerulus filtration rate. And as a compensatory mechanism, we have increased sodium and water retention. This will lead to the blood volume increase. This is number one. This is through the blood flow to the kidney, and we have another pathway through the renin, and we already discussed and covered that on the top of the slide. So we need all of us to be familiar with this system here. So I will repeat it again. I will go to the whiteboard. Okay, decreasing blood pressure will activate two systems. Will activate sympathetic system and activate renin, angiotensin, aldosterone system. Activating sympathetic system will stimulate beta 1 and alpha 1. Okay, this one will increase level of angiotensin 2 and aldosterone. This one will increase peripheral vascular resistance, and we discuss the situation. This maybe beta 1, we talk about too many places. We talk about heart, and we are speaking about renin and the kidneys. So this is maybe for simplicity, this is what we have for the blood pressure, and the end result, you can see here we have increased cardiac output, increase peripheral vascular resistance, and the same. Okay, sodium and water retention. So all these will lead to the increased blood pressure. So this is maybe summary for the compensatory mechanism for the hypotension or decreased blood pressure. Okay, moving to the treatment. Goal for blood pressure. Okay, goal for chronic treatment of hypertension. Okay, goal for chronic treatment of hypertension. So what are the goals? So most patients, including patients with a clinic atherosclerosis, cardiovascular disease, diabetes, or CKD, most patients, our goals, the blood pressure we be looking for less than 130/80. So this is our goal for most patients with the CKD, diabetes, cardiovascular disease, less than 130/80. Elderly, for older people, older ambulatory, community dwelling patients, systolic blood pressure less than 130. Older patients, those with a high disease burden, comorbidity, and limited life expectancy, such as end-stage cancer, for example. Here, for those patients, we accept the blood pressure to be less than 150 or 140. So here, when we have end-stage disease and patient is very weak, we accept the 150, 140. We are not going to be strict for those patients. But for a chronic patient, normally, for the chronic patient, so our desired number will be less than 130/80. Okay, non-pharmacological approach for management of hypertension. We recommend patient to lose weight if the patient overweight or obese. Dietary approach to go to the DASH diet, which encourage fruit and vegetable and avoid fat and red meat. Reduce salt intake to 1.5 gram per day, or for sodium 3.8 gram per day for sodium chloride. Physical activity 90 minutes, 150 minutes per week of training. Limit alcohol intake, 2 drinks for men and 1 drink for women. Smoke cessation and reduce cardiovascular risk, and should be encouraged. So all these, we have to start with this approach before we start medication or drug treatment. Losing weight if the patient is obese or overweight. Adopt a DASH diet, fruit, vegetables, and avoid fatty food. Reduce salt intake. Physical activity, limit alcohol, smoking cessation. Okay, this is a DASH diet, DASH diet here, or like lifestyle modification, lifestyle modification change. If the patient decrease weight, okay, losing weight, maintain normal body weight, we recommend patient body weight index to be between 18.5 24.9 kilogram per square meter. Okay, this will decrease blood pressure by 5 points. Okay. Okay, so if the patient decrease weight or losing weight, and body mass index become between 815 and 24.9 kilogram per square meter, the patient will lose 5 points on the systolic blood pressure. Okay, moving to the DASH diet, which means a lot of fruits, vegetables, and low fat and dairy products. Limit intake of saturated fat. This will decrease the blood pressure by 11 points. Reduce salt intake, minimize daily sodium intake, ideally 1.5 gram per day, 3.8 gram with chloride sodium. Okay, this will reduce blood pressure 3 to 5 points. Speaking about physical activity, we encourage people to engage in the training like dynamic aerobic training, about 150 minutes per week. So could be like 20 to 40 minutes per day and exercise. This will lose weight. This will lead to the decreased blood pressure by 4 to 8 points. Limit alcohol intake, 2 drinks for men and 1 drink for women. This will reduce blood pressure by 4. We try to calculate all these points. If the patient follow all these, the patient blood pressure will decrease 32. Systolic blood pressure will be decreased 32 points. So if the patient comes to the clinic and his or her blood pressure like 152 minus 32, the blood pressure will become 120. This is normal blood pressure. So here we don't need medication, no drug needed if we follow the lifestyle modification. Okay, treatment strategy and blood pressure goals. Okay, the goals of blood pressure to reduce cardiovascular, renal morbidity, mortality. We know that if the blood pressure left untreated, the result will be renal failure or cardiovascular disease. For most patients, our goal for systolic blood pressure to be less than 130, diastolic less than 80. Current recommendations for treatment. What treatment should I use? Okay, we have thiazide, ACE inhibitor, angiotensin receptor, ARBs, calcium channel blocker. So we have, this is a current recommendation: diuretic, ACE, ARBs, CCB. Okay, this one here, the last one. Okay, initial drug therapy choice may vary depending on the guidelines. We are going to discuss that. If the blood pressure inadequately controlled, we need to add a second medication. So it depends on the situation. So I'll go back again to remind you of the goals and strategy. Now we have a patient, 55-year-old male. Okay, non-Hispanic, black, ethnicity, has hypertension, along with a medical history of diabetes, hyperlipidemia. So we have 3 main disease: hypertension, diabetes, hyperlipidemia. According to the American Heart Association and ACC, which of the following option best reflect the most suitable blood pressure target for this patient? This one is not correct. 140 over 85, 135 over 85. This is a correct one. Okay, this is a correct answer, less than 130 over 80. Okay. Okay, now we move to the antihypertensive drugs group of medications. The main group of medication, I will repeat, the main group of medication: ACE inhibitor, angiotensin converting enzyme inhibitor, ARBs, angiotensin receptor blocker, calcium channel blockers, diuretics, beta blocker, and others. So we have several groups of medication available for treatment of hypertension. This slide here, or this picture, show the medication name, the group of medication, the class of medication, the medication name, the brand name, what dosage should be used, and how often we need to use it. We start with the first one, alpha blocker. We have doxazocin, brazosine, terazosin. You can see here, okay, doxazocin, for example, once daily. Okay, so the student here need to remember at least the class and the generic name. Brand name is important for the practice, and this one they rely on the practice during your clinical rotation. Doxazocin, brand name Cardora, brazosine, Menebres, terazosin, and other maybe medication for belong to another group. So this one, the doses, you will going to learn it during your practice. So alpha 1 blocker, we have 3 medication: doxazocin, brazosine, terazosin, and then second and third drug 2 to 3 times. But if you talk about doxazocin, once per day. Direct renin inhibitor, we have Aliskiren, Tactorna, once daily, and available 150 to 300 milligram. Okay, Aliskiren, Tactorna, central alpha 2 agonist, clonidine, Catabres, clonidine batch, and then we have methyl dopa. Methyl dopa will be drug of choice for a pregnant woman with hypertension. Okay, methyl dopa, Aldomet. Direct arterial vasodilator, we have minoxidil, and hydralazine, Adrenergic. So we need this, we need you to remember the group name, class name, medications, and brand name for your practice: Cardora, doxazocin, Tactorna, Aliskiren, Catabres, clonidine, abrolizine, hydralazine, Aldomet, methyl dopa. Okay, moving to the next slide. Here we have, so we already present the medication name, group of medication, and we are going to discuss later on. In the market, we have combination treatment, more than one medication. For example, we have ACE inhibitor and diuretic, ARBs and diuretic, CCB. We can come back again to this slide to discuss the combination. We have 2 lists of combination treatment. Another combination. Okay. So, okay, the first group of medication used to treat hypertension, diuretic. Diuretic is a group of medication that decrease blood pressure, decrease blood volume, and this medication, we know that increase excretion of sodium and water in the urine, and this will lead to decrease blood volume. And from the equation, you know that this will lead to the decreased cardiac output, and the result will be decreased blood pressure. Now we understand how the diuretic decrease blood pressure. We have another mechanism, but they try to remind us we need to monitor the electrolyte for this patient. We need to, for example, to do the blood test every 3 to 6 months or once per year for sodium, potassium, magnesium, calcium, chloride. This electrolyte is very important for the balance to be balanced in our body, and the diuretic will be adversely affect these ions. 3 group of medication available: thiazide, loop diuretic, and potassium sparing. mainly for hypertension. But talking about diuretic, we have more than maybe 5 group or 6 group. So we are going to discuss diuretic and the diuretic chapter, not now. But this is the most popular medication, most popular diuretic used for the hypertension: thiazide, loop diuretic, and potassium sparing diuretic. Okay, so diuretic, as we discussed, decrease blood volume and decrease blood pressure. We need to monitor electrolyte. 3 group of medication. As you can see here, we have thiazide, class of diuretic, loop diuretic, potassium. Then they add here something, mineral receptor antagonist. Mineral receptor antagonist, we are speaking here about aldosterone antagonist. Aldosterone antagonist. Aldosterone antagonist. Okay, so we what we have here, speaking about the group of medication. For example, for thiazide, we need student to understand, or the people to understand. We have chlorthalidone, we have hydrochlorothiazide, microzide, and dopamide, metalazone. All these thiazide diuretic, and we have the usual dose and frequency, how often we use it per day. Loop diuretic, we have furosemide, Lasix, furosemide, bumetanide, Bumex. We have torsemide. This is the 3 most important diuretic belong to the diuretic, and we have some details about number and usual dose. Potassium sparing diuretic, amiloride, hydrochlorothiazide, and then we have triametrin. Regarding to the mineral corticoid receptor antagonist, we have eplerenone and spironolactone. So MRA stand for mineral corticosteroid, okay, receptor antagonist. And we have 2 medication, eplerenone and aldosterone. We have a new medication now in the market called finerenone. New medication, Carinda. Okay, so speaking about the first group of medication for thiazide, for example, thiazide lower blood pressure by increasing sodium and water excretion. We know that increases sodium and water excretion in urine. Number 1, they found with a long-term treatment, the effect of hypotensive effect related to the decreased peripheral resistance. So the maybe quick effect here will be increased excretion of sodium and water, but with the long-term treatment, they found this medication cause decreased peripheral resistance. So we have 2 main mechanisms. The initial thiazide diuretic can be used as initial therapy for hypertensive unless there are compelling reason to choose this another agent. So initial therapy, let me say, like we have 55-year-old patient, everything normal with this patient, and the blood pressure 145 over 95, for example. And after following all the lifestyle modification, the blood pressure remain high, we can start the treatment with the thiazide. So we have 55 old, blood pressure high, everything normal, so thiazide could be the drug of choice. This is number 1. Number 2, the patient could be used thiazide as a combination therapy with other medications, such as, for example, ACE inhibitor plus thiazide. So we have, at the end of this lecture, we have 2 slides about combination. Could be ARBs plus thiazide. So we have a group of medication regarding this combination treatment. Loop diuretic. For loop diuretic, we have furosemide, torsemide, bumetanide, ethacrenic acid. These medication work promptly by blocking sodium chloride absorption in the kidneys. We need to say more to be more accurate here. These loop diuretics block sodium, potassium, 2 chloride co-transporter. So this medication, group of medication, and we talk about loop of Henle in the nephron. Okay, this is number one. And loop diuretic work even in patient with impaired renal function. When this number one, or when we prescribe thiazide but the patient did not respond to the thiazide, the alternative will be loop diuretic. Loop diuretic rarely used for the heart hypertension, but commonly used for the heart failure. So in this case here, I have two cases. They said if the patient suffers from hypertension, popular medication will be thiazide. Okay, if the patient suffers from heart failure, popular diuretic will be furosemide, loop diuretic. Does that make sense for us? So what happened here? For the heart failure, we go with the loop diuretic. For the hypertension, thiazide. So it depends on the situation. We select our diuretic. Okay, moving to the potassium diuretic, potassium sparing diuretic. We have two groups of medication. The first group affect the sodium transporter, inhibit the sodium transporter and the late distal and collecting ducts in the nephron. Okay, we have amiloride and trimetrin. So two medication, amiloride, trimetrin, inhibit sodium transporter in the distal tubules and collecting duct. It's number one. Okay, the first group inhibit the transporter, amiloride, trimetrin. What about spironolactone and eplerenone? Spironolactone, eplerenone considered like aldosterone antagonists. This is important things here. So for this reason here, okay, so when we talk about spironolactone, inhibit aldosterone receptor, antagonize the aldosterone receptor. This will lead to the increased excretion of sodium and water and decrease excretion of potassium. Here we are speaking about urine. Okay, if we have decreased potassium in urine, the result will be accumulate of potassium in the blood. So if this medication decreases potassium, the result will be decreased elimination in the blood, and the patient may suffer from hyperkalemia. Okay, so I'll repeat this one. Spironolactone block aldosterone receptor. This will lead to antagonize action of aldosterone by increased excretion of sodium and water in urine and decreased excretion of potassium. This will lead to the accumulation of potassium and lead to the hyperkalemia. So we need to remember this hyperkalemia because we are going to see it and we are going to deal with this situation in patients with heart failure that was covered already in the previous video. Okay, all these agents reduce potassium loss in the urine and cause hyperkalemia. Aldosterone antagonist has additional benefit of the administering diminishing cardiac remodeling, that occur in heart failure. Now we have another benefit here. The first benefit, used for hypertension and retain potassium. The second benefit, decrease cardiac remodeling in patients with heart failure. Normally we use this potassium diuretic with the loop diuretic or thiazide to reduce risk of potassium losing in the urine. So sometimes you can find thiazide plus spironolactone, and the purpose to prevent losing potassium in the urine. Okay, here what we have, a group of medication we already covered. We have thiazide, generic name hydrochlorothiazide, chlorthalidone, hydrochlorothiazide, then we have indapamide, metalazone, and then we have the detail about brand name, dosing, half-life. Loop diuretic, we have furosemide, bumetanide, torsemide, and ethacrinic acid. Then we have Lasix, for example, here, Biomex, Dimadix, and Edicrine. Talking about sparing potassium sparing, we have amiloride, triametrin, for the aldosterone antagonist receptor, Ebrenone and spironolactone, and then we have Finrenone, new maybe medication for the heart failure. Okay, now we have matching. We have matching with drugs for the like exercise, and we are going to work with you together to solve this situation. What we have here in this column here, we have diuretic name, and another column here, the second column, we have the description for mechanism of action. So we are looking for the mechanism of action. This medication work on the sodium chloride transporter in the distal convoluted tubule. Distal convoluted tubule work on sodium chloride, hydrochlorothiazide. Okay, this medication work on the sodium potassium chloride co-transporter and the loop of Henle. So which of the following on the list here belong to the loop of Henle? So if you said B is correct. So for B, if you said furosemide, you are correct. So A is our number one will be the correct answer for B. This medication blocks sodium channel in the collecting ducts. So what we have here, we are looking for medication block sodium channels. The correct answer will be amiloride. Okay, this medication block the effect of aldosterone and on mineralocorticoid receptors. The correct answer will be spironolactone. So this like matching question between these medication here, for example. Okay. This is a match the drug of action with the site of action on the nephron in the kidneys. Okay, you can see here the correct answer. Furosemide, amiloride, spironolactone, hydrochlorothiazide. Okay, here we only the purpose of this slide to show the diuretic plus other medication. Diuretic plus ACE inhibitor, for example, benazepril hydrochlorothiazide, enalapril hydrochlorothiazide, Vasodilators, Lotensin, monobril hydrochlorothiazide, fosinobril, lisinopril hydrochlorothiazide, moxibryl hydrochlorothiazide, and then we have ARBs, azisartan, hydrochlorothiazide, candesartan, hydrochlorothiazide. So we have ARBs plus diuretic, we have ACE plus diuretic. Okay, again we have a combination between beta blocker and thiazide, atenolol, bisoprolol, metoprolol, nadolol, propranolol plus diuretic, tenoritic, Zayac, Librosor, hydrochlorothiazide, Corzide, so propranolol plus hydrochlorothiazide, Tictorna HL, Aliskiren hydrochlorothiazide, Renin inhibitor, Renin inhibitors. Then we have spironolactone hydrochlorothiazide, aldactazide. Okay, CCB. Here we have triple therapy. Amlodipine, valsartan, hydrochlorothiazide, X-Forge. Olmesartan, amlodipine, hydrochlorothiazide. Okay. Okay, next slide here we are speaking, or this slide speaks about beta-adrenoreceptor or blocking agent, beta-adrenoceptor blocking agent. We talk about something called beta blocker. Talk about beta blocker. Beta blocker, how this medication work in hypertension, how the mechanism of action. This medication primarily reduce blood pressure by decreasing cardiac output. So number one, decrease cardiac output. Number two, this medication decrease sympathetic outflow in the central nervous system. So work on the central nervous system by decreasing sympathetic outflow. Number three, this medication inhibit release of renin. Inhibit release of renin. So we have two main effects: decrease cardiac output, inhibit sympathetic system in the central nervous system, and inhibit renin release. We have other main effect, for example, enhance release of nitric oxide, for example. Other maybe theories talk about increased potassium level in the blood vessels. So we have several theories, but the main mechanism for beta blocker will be decrease cardiac output, inhibit sympathetic pathway in the central nervous system, and inhibit release of renin. But we need to keep in mind sodium and nitric oxide and potassium for the later on. Okay, so a group of medication belong to the beta blocker. Propranolol, considered like prototype, block both beta 1, beta 2 receptor. Metoprolol, atenolol, selective beta 1 receptor. I will repeat again, metoprolol, atenolol, considered like selective beta 1 receptor, and the most commonly prescribed use beta blocker because they are selective, and we prefer to use medications that consider selective medication. Okay, moving to the nebivolol. Nebivolol is selective beta 1 receptor, and they found this medication, this beta blocker increased production of nitric oxide. I like this medication. Nebivolol medication increased nitric oxide, and if you like to maybe remember this medication, nebivolol start with N, and this medication increased nitric oxide start with N. So which of these beta blocker increase release of nitric oxide? Nebivolol. So then we move to the selective beta 1 receptor. We have some instruction, should be used cautiously in patients with diabetes or hypertension. Selective, such as beta 1, beta 2. Non-selective, such as propranolol, is contraindicated. Not allowed to use in patients with asthma. So if the patient suffers from asthma and hypertension and come to the clinic for treatment, and you decide to prescribe beta blocker, it's not allowed to prescribe enteral propranolol because propranolol may cause a bronchial constriction or bronchoconstriction and lead to the exacerbation of asthma. Okay, non-selective beta blocker, selective beta blocker, mixed. We need to remember this list. It's very important list for us. Okay, I will go back again to the list. Okay, for cardioselective, atenolol, very popular medication, tenormin, metoprolol. We have two types of metoprolol, metoprolol tartrate, Librosor, and metoprolol succinate, extended release toprol XL. Then we have nebivolol. Okay, for non-selective. So again, for cardio-selective, that means we talk about beta 1. Okay, for cardio-selective, atenolol, betaxolol, bisoprolol, metoprolol, nebivolol. Okay, nebivolol, metoprolol, we have two types, tartrate and nebivolol, metoprolol, succinate. Metoprolol tartrate, Librosor, and succinate for the Toprol XL. This medication will be ideal for patients with heart failure, but we have to be careful which stage or which class will be good option for patients with heart failure. But for heart failure, for example, we have other option, best option, ACE inhibitor. Then we have ARBs. Then we have for example, we have MRA. Okay, and another option will be beta 1 blocker. So this is the first choice for heart failure. Okay, for non-selective, we have nadolol, propranolol, this is prototype, Endiral. Then we have timolol. Regarding the mixed alpha and beta blocker, carvedilol and labetalol. Block beta 1, beta 2, and alpha. Carvedilol, labetalol. Then in this list we have the brand name, generic name. Here we have generic. This is a generic, and then we have the brand if available in the market. Okay, moving to the therapeutic use, beta blockers used for patients suffer from hypertension. Okay, but not first choice. Number 2, patients suffer from chronic heart failure. Number 3, use it for angina and MI. And number 4, for patients with high risk of coronary artery disease. So this is maybe the clinical use of a beta blocker in general: hypertension, congestive heart failure, angina, high risk of coronary artery. So we don't prefer to use beta blocker in the following group: patient with asthma, patient with severe peripheral vascular disease, patient with second or third heart block. So I think here, I believe here we need to explain. We need to explain why we don't prefer to prescribe beta blocker to the patient with asthma. Why don't prescribe beta blocker to the patient with a second or third degree heart block? Then why we don't prescribe beta blocker to patients suffer from peripheral vascular disease? I'm going to switch the slide, moving to the whiteboard to explain a little bit what happened. So we have 3 cases here for beta blocker. We don't prefer to prescribe it. Okay, beta blocker. Okay, not prefer to prescribe in patient with asthma. Not prefer to prescribe to patient with a second and third degree heart block. And not prefer to use to the patient with a peripheral, okay, vascular or vascular, okay, disease. I'm going to explain a little bit why we don't prefer to prescribe it. So regarding to the asthma, according to our knowledge in pharmacology or autonomic nervous system, we know that in the bronchial tree we have main receptor. In the bronchial tree main receptor we have beta 2 receptor, β-Adrenocertic receptor, and the study found that if you stimulate beta receptor, the result will be bronchodilation. Okay, that's great. Okay, what happened if you block the receptor? So you prescribe beta blocker to your patient. Beta blocker will block the beta 2 receptor in the bronchial tree. The result will be bronchoconstriction. Okay, for this reason here, we talk about non-selective here. For this reason, we can say that beta blocker, non-selective beta blocker, is contraindicated in patient with asthma. Now we understand why non-selective beta blocker is contraindicated in patient with asthma. The second one, speaking about I will take the heart block, second or third heart block. When you speak about heart block, that means the heart will pump then stop, pump then stop. So what happened there? We have decreased heart activity. Okay, this is a heart block. This is a disease, second or third degree heart block, decreased heart activity. And we have on the, for example, if you look on the ECG, you can see the EKG like this one. Then we have stop, then back again, then the heart will be stopped again. So we have here maybe this period is like we don't have any beat. So the heart pump the blood, then stop, then pump, then stop. So for this reason here, if you prescribe beta blocker will be block the heart. So beta blocker will be aggravate the situation, make the situation worse. Okay, for this reason, we don't prefer to prescribe beta blocker for patients suffer from second or third degree of heart block. The last one, peripheral vascular disease and beta blocker, we don't prefer to use it. We need to explain why. Important issue here, very important issue. Okay, so what we have here, to maybe refresh your mind, okay, we have the blood vessels. And the blood vessels, they found, this is blood vessels here. This is peripheral blood vessels. We have two types of receptor. We have beta 2 adrenergic receptor. We have alpha 1 adrenergic receptor. This is a normal physiology in the blood vessels. Okay, alpha 1, when you stimulate alpha 1 in the blood vessels, the result will be peripheral vasoconstriction. And we call this one peripheral vasoconstriction resistance increase. Okay, beta 2 work as opposite action to alpha 1. If you stimulate beta 2, the result will be vasodilation. Okay, that's great. So you can look what we have here. We have balance. We have balance between alpha and beta. We have like scale between alpha 1 and beta 2 in the blood vessels. Here we are talking about peripheral blood vessels. So we have peripheral blood vessels and we have balance here. That's great. Okay, you can imagine now you have patient come to the clinic. We have patient come to the clinic, and this patient need to give him like a beta blocker, just such as propranolol to treat migraine or for the prevention of migraine. Okay, what happened here? Beta blocker block beta 1 and block beta 2. So this one, when you block beta 1, we understand what happened. Decrease cardiac output, decrease renin. Okay, that's great. And the blood pressure will be decreased, decrease blood pressure, and affect the brain and improve symptom of migraine, for example. But for beta 2, you can imagine now beta 2. You block beta 2. Beta 2 available in the blood vessels. Okay, I will go with the green here. Now our medication here, beta blocker, you prescribe it. What happened? You block beta 2. Okay, what happened? You block beta 2. If you block beta 2, okay, that you can imagine now we have, like, I will maybe change this one now in the image. You remember we have balance between beta 2 and alpha 1. If you block beta 2, okay, I will make it small in order to compare. Okay, this is the blood vessels again here. We have beta 2 and alpha 1. Okay, and alpha, let me go there. Okay, alpha 1. So you can imagine now we have balance, and you block, when you block alpha beta 1 by, when you block beta 2 in the blood vessels. So what happened here? You can imagine now we are working on the, you have river, and you have 2 branches for the river, and this branch here like beta 2, and the branch here is alpha 1. So what happened here? If you block the beta 1, the alpha 1 river will be enhanced, activated. You agree with this one? So this one will be activated, alpha 1, alpha, this one, all these activated here. Activate alpha 1. So when you activate alpha 1, what happened to the blood vessels? The result will be increased risk of vasoconstriction. Okay, that's great. And here we are talking about peripheral vessels in the fingers, in the hands, in the extremities. For this reason, the situation become worse if the patient suffers from Raynaud's syndromes or claudication due to the spasm of the coronary artery. For this reason here, we don't prefer to use this medication for patient with the peripheral artery disease. So you can see here what we have according to the explanation. I will go back again only to be sure we are on the same page. We already explained what happened there, explain the river issue here, what we have, and then we have the balance, and then we speak about what happened on the blood vessels. Okay, moving to the group, continue talking about the contraindication and adverse effect. Patient may suffer from bradycardia, heart blocks, bronchospasm, exercise intolerance, and sexual dysfunction. We don't know exactly the mechanism. Sexual dysfunction, we have question mark, we have explanation mark. What happened? Why? Sexual dysfunction, beta blocker involved in this side effect. Beta blocker mask symptoms of hypoglycemia. Beta blocker cause metabolic effect, hyperglycemia, dyslipidemia. So if the patient suffers from diabetes, we have to be careful. Can we explain why here? Okay, going back again to explain why. So beta blocker. Okay, then we have diabetes mellitus. Patient with diabetes mellitus, if the patient during the treatment or the course of disease or treatment, if the patient suffer from hypoglycemia, okay, the situation here, when the patient suffer from hypoglycemia, this will activate sympathetic system. For this reason, when the patients maybe suffer from activated sympathetic system, the patient starts suffering from sweating, from tremors, for example, and from palpitation. The heart rate will be increased. Okay, so all these considered like warning symptoms. So we have here warning symptoms of palpitation, tremors, and sweating. if the patient, for example, taken beta blockers, you prescribe beta blocker to the patient. So you have patient, for example, here, diabetic patient come to the clinic and you prescribe beta blocker to treat hypertension, and they found beta blocker. What happened to the beta blocker? Beta blocker, they said, beta blocker block sympathetic system. So when you block sympathetic system, you mask symptoms of hypoglycemia. Okay, so the patient will suffer from severe hypoglycemia and make the maybe patient prevent to maybe progress to the coma and could be death. So for this reason here, we don't prefer to prescribe non-selective beta blocker to the patient suffer from diabetes, because beta blocker mask symptoms of hypoglycemia. Mask symptoms of hypoglycemia. If you go into the slide there, so you can see here, beta blocker mask symptom of hypoglycemia. Okay, so regarding, I will maybe summarize information about beta blockers. We need maybe the student to understand the situation here. I will go back to the slide. We need the student to understand how this medication work, the mechanism of action. This medication work on the heart, decreasing heart rate, work on sympathetic system, decreasing outflow of sympathetic system, and decrease or inhibit release of renin. Then we have, we need to remember the major drug, propranolol, non-selective, metoprolol, atenolol, selective beta-1 receptor, nebivolol. This medication, beta-1 receptor, in addition to the increased production of nitric oxide. Regarding the non-selective with selective beta blockers, we need to be could be used cautiously in patient with asthma, for example. But if you talk about a non-selective beta blocker, consider like contraindicated in patient with asthma. So we're going to explain why this is contraindicated. And we have list of medication here. We need to remember with which of these medication need to be used. Okay, list of medication again. Here we have the indication for we use beta blocker number 1 for the treatment of hypertension, plus we use it for heart failure, myocardial infarction, and coronary artery disease. Beta blocker, we don't recommend to use it in patients with asthma, in patients with heart block, and patient with peripheral vascular disease. We already covered these maybe topics or this area of maybe cautions. Adverse effect, we discussed bradycardia, heart block, bronchospasm, exercise intolerance, sexual dysfunction, unknown mechanism why the patient suffer from sexual dysfunction. This medication may cause hyperglycemia. If the medication causes hyperglycemia, that means we don't recommend to use it in patients with diabetes mellitus, even type 1 or type 2 diabetes, because beta blocker causes hyperglycemia. This is number 1. Number 2, we discuss how this medication masks symptoms of hypoglycemia and may increase risk of coma and death without any warning symptoms. The last one here we need to maybe to figure out or discuss it was abrupt withdrawal effect. Abrupt withdrawal effect, I think this is an important one. They found if the patient stopped this medication suddenly, okay, if you stop this medication suddenly, abrupt withdrawal, this medication, this will lead to the severe hypertension, angina, myocardial infarction, and even life-threatening cardiovascular event, and even sudden death. For this reason, we recommend patients to decrease this medication gradually over a few weeks, 2 to 3 weeks time, in order to avoid this overstimulation of the receptors. If you go to the whiteboard to explain what happened there. Okay, So we have a concept called two concepts. The first concept called upregulation. Upregulation receptor. And we have another concept called down receptor. Downregulation receptor and upregulation receptor. So for the upregulation receptor, what happened here? When you prescribe, that we have number of receptor here, and I will maybe put it there like number of receptor. Let me say we have 3 receptor, for example here, and we have another 3 receptor for another case. So we have 2 cases here. This is a normal subject, not normal healthy subject. If you prescribe something to block the receptor, such as beta blocker block the receptor. So our body will try to upregulate the receptor. What that mean? So our body will try to build a new receptor. So to build or synthesize or generate a new receptor. All these considered like new receptor. And you can imagine now we have a new receptor. So all these receptors will be waiting to be active or activated. So in this case, you can imagine now we have beta receptor. When you block the receptor, our body tries to increase number of receptors. So here what we have, the result will be increase number of receptor. Okay. On the other hand, when you prescribe like agonist, I will say, for example, agonist here. Okay, the situation will be when you prescribe agonist, this stimulate the receptor. So our body response will be, the response of our body will be, okay, decrease number of the receptors. So I hope this maybe makes sense. Now you can imagine the patient already on beta blockers, and he has a lot of receptor generated, and you decide to stop this receptor suddenly. So what happened there? When you stop this receptor suddenly, all these receptors will be reactivated. And reactivated this receptor will increase blood pressure for the high grade of very increased or stimulated of heart, and there's a risk of angina and risk of MI or even risk of stroke. Okay, for this reason here, okay, I will go back to the slide. For this reason, as you can see here, we don't recommend, okay, we are good. Okay, for this reason here, we don't recommend the patient or the healthcare provider to stop this medication gradually, because the situation will be hypertensive crisis. Okay, here we have list of medication for combination therapy. Maybe we can read it at our time, free time, when you have time. For example, we have spironolactone with hydrochlorothiazide, irbesartan hydrochlorothiazide, olmesartan hydrochlorothiazide, and we have Diovan, for example, valsartan hydrochlorothiazide. This is combination between the list of medication. Okay, so moving to the question about beta blocker. The question here, what adverse effect is linked to the use of beta blocker? What adverse effect used to the adverse effect linked to the use of beta blockers? Hypertension, hyperactivity, exercise tolerance, or sexual dysfunction? So if you choose sexual dysfunction, you are correct, and the mechanism unknown. Okay, how should beta blocker appropriately stopped in individual treated with ischemic heart disease and hypertension? Sudden cessation, gradual tapering. What do you think? This is wrong. Gradual tapering over a few weeks. This is correct. Immediate switch, wrong. Perpetual continuation of beta blocker therapy, wrong. So this is maybe the answer for this question. Antihypertensive medication. For another group now, we are going to speak about two groups of medication, ACE inhibitor, angiotensin converting enzyme, and we are going to speak about ARBs, angiotensin receptor blockers. Here we students need to remember we have Brel, we have benazebrel, captopril, enalapril, fosinopril, lisinopril, Zistril, we have moxibrel, brindopril, kinapril. List of medication end with the Brel. Okay, ARBs, the suffix here, sartan. And almost we cover all these medication in our lecture in drug use for heart failure. I will leave the link in the description for more information about drug use for heart failure, which is available in the YouTube channel. For the ARBs, we have azlisartan, candisartan, ebrosartan, irbesartan, losartan, Cozar. For example, we have Binicar, olmesartan, Diovan, valsartan. So we have list of medication. Okay, starting with the ACE inhibitor. This is very important medication for patients with hypertension. As you can see here, we have captopril, enalapril, lisinopril, recommended as first-line therapy. So what is the first-line therapy for the treatment of hypertension? ACE inhibitor. Please remember this one here. This is, maybe we can consider this one for any patient with hypertension. But please remember we have patient. We have to look on other, for example, symptoms or case or disease or maybe combined disease. Okay, first-line therapy for hypertension, ACE inhibitors. And this one will be great option for patients suffer from hypertension plus okay, coronary disease, hypertension and diabetes, hypertension and stroke, hypertension and heart failure, myocardial infarction, chronic kidney disease. This is a great medication. Okay, moving to the how this medication works. This medication reduce peripheral vascular resistance without affecting the heart rate. So no effect on heart rate, no effect on contractility. This medication works mainly on the peripheral vascular resistance. This is a exam question on the national level or BANS exam, USMLE exam. ACE inhibitor reduce peripheral vascular resistance and with no effect on the cardiac output, heart rate, and contractility. Okay, by blocking this enzyme, okay, the angiotensin 2, when you block angiotensin 2 considered the most potent vasoconstrictor, and we block this mediators there, angiotensin, and the result will be decreased peripheral resistance. On the other hand, we need this enzyme, ACE inhibitor, angiotensin converting enzyme, for the breakdown of bradykinin. Bradykinin is like a mediator. It's important to induce vasodilation. So the ACE inhibitors break down ACE angiotensin converting enzyme break down the bradykinin, and the bradykinin induce nitric oxide and the prostacyclin and cause vasodilation. That's great. So now we have mechanism speaking about how this medication work. For the ACE inhibitors, inhibit angiotensin 2. Okay, and this will lead to the decreased formation of aldosterone. On the other hand, this will lead to the increased formation of bradykinin. This will lead to the enhanced formation of nitric oxide and prostacyclin, which means prostaglandin I2, and here will lead to the vasodilation. That's great. So we have, as you can see here, we have so many, several or multiple mechanisms of action related to the ACE inhibitor. ACE inhibitor reducing the, as you can see here, decrease circulation, secretion of aldosterone. ACE inhibitor reduce both cardiac preload and afterload. Maybe we need to discuss that, why this decrease preload and afterload. And this one is already covered. I will in heart failure lectures, and I would like to refer students to the heart failure lecture to understand why ACE inhibitor decrease afterload and preload. Okay, therapeutic uses. I like what we have here. What they found here, the ACE inhibitor considered like a drug of choice for patients with hypertension and plus diabetes, and the main reason they found is like slow progression of diabetic nephropathy, decreased albuminuria. So this medication could be the attractive therapy for patients with the hypertensive and diabetes, because slow progression of diabetic nephropathy. This medication could be used for after myocardial infarction as a first-line agent. So now for the first-line agent, we have hypertension. First-line agent for the heart failure, as you can see here. Okay. First-line agent for the heart failure and coronary disease. I will type here another one, coronary artery disease. So ACE inhibitor could be or considered like first-line agent for hypertension, heart failure, and coronary artery disease. Here we can explain a little bit of pharmacokinetic. All ACE inhibitors undergo hepatic conversion to the active metabolite, and the only exceptions, we have two medications. They don't metabolize by the liver, captopril and lisinopril. So all ACE inhibitor metabolized by the liver and convert to the active metabolite. So therefore, these agents may be preferred in patients with a severe hepatic impairment. So there's a question now, which agent preferred in patients with severe hepatic impairment? The answer will be captopril and lisinopril. So captopril and lisinopril is the preferred agent in patients with hepatic impairment. We don't prefer other medication from ACE inhibitor. Fasenopril is not eliminated primarily through the kidneys. So fasenopril not eliminated through the kidneys, and that does not require the dose adjustment in patients with renal failure. That's great. So now we have another case. If the patients are from hepatic disease plus hypertension, so the best medication will be lisinopril. If the patients suffer from renal impairment, renal disease plus hypertension, the preferred medication will be fasenopril. And we have maybe the rationale or explanation here. Okay, no need for adjust the dose. Okay, now what we have, if we talk about the important issue here with the patient, we have so many side effects, but we focus on the major side effect. Even if rare, we have rare side effects. So what we have here, they said adverse effect of this medication, dry cough. 10% of patients may suffer from dry cough, and the reason related to the increased bradykinin and substance B in the pulmonary trees. And the second one will be angioedema, rare but could be life-threatening reactions, angioedema, and due to increased level of bradykinin. So two side effects here belong to the increased level of bradykinin, and for this reason here we need to monitor the patient during the 30-minute to 1 hour in the clinic before they leave the clinic, to be sure the patient is not maybe predisposed to the dry cough or to the angioedema, not for the dry cough. Okay, moving to the pregnancy now. We have pregnant woman, for example, and she has high blood pressure, pregnant woman, okay, and suffer from high blood pressure. Okay, according to the literature, medical literature, they said, okay, ACE inhibitor induce fetal malformation, fetotoxic. For this reason, it's contraindicated during pregnancy. It's not allowed to use ACE inhibitor during pregnancy. So here we need to maybe remember and understand the situation. We don't recommend to use ACE inhibitor during pregnancy. Okay, so what we can see here on the graph, I think is very important topic for us. This is the pathway or cascade for the renin angiotensin. We call this one. I will go back. We call this one renin angiotensin aldosterone system, RAS. So first, from the beginning, the liver will produce substance called angiotensinogen. And this angiotensinogen will be converted to the angiotensin 1 under the effect of enzyme called renin. Renin produced from the kidney, as you can see here. Okay, angiotensin 1 will arrive to the blood vessels. And under the effect of enzyme called angiotensin converting enzyme, will convert angiotensin 1 to angiotensin 2. Okay, this is number one. Angiotensin 2 will affect the kidney and the cardiovascular system. Affecting the kidney, stimulate the kidney to release aldosterone, and aldosterone will lead to the sodium and water retention, increase excretion of potassium in urine, and this will lead to the what do you think here? Hypokalemia. Okay, it's not our topic now for this one, but it's correct statement, very important. Okay, decrease or responsible for balancing of potassium in the blood. Okay, this is the effect here. So moving to the what happened when you retain sodium and water, the blood volume will be increased. And this will increase cardiac output and lead to the increased blood pressure. Here I would like to refer student again to the heart failure lectures to understand this cascade, because it's explained in details in the heart failure and clinical pharmacology of heart failure. Okay, so this is the first mechanism here. Okay, and moving to the second one. The first mechanism, stimulate aldosterone. The second one, angiotensin 2, considered like most potent vasoconstrictors. So the situation will be vasoconstriction. So you can see we have synergistic mechanism. Affect the kidney, affect the heart, vasoconstriction, aldosterone, retain sodium and water, increase blood pressure. Here we try to maybe show us what happened. This enzyme is important to metabolize bradykinin to the inactive substance. This we need to keep this in our mind. Now we are talking about our medication, ACE inhibitor. This is the ACE inhibitor, inhibit the action of the enzyme ACE inhibitor. Okay, so what we have here, we have the ACE inhibitor inhibit the enzyme, and the result will be decrease angiotensin 2. When you inhibit the enzyme, the result will be decrease angiotensin 2, and we have 4 main actions, very important action for us. 4 main actions. Number 1, vasodilation. We understand the situation why, because angiotensin causes vasoconstriction. If you inhibit angiotensin, the result will be vasodilation. Great. Moving. Angiotensin, when you decrease activity, the result will be decrease sympathetic nervous system activation, decrease the aldosterone secretion, decrease sodium and water retention, and enhance bradykinin secretion. The result will be vasodilation, decreased blood volume, decreased vasoconstriction, and sympathetic, and the end result will be decreased blood pressure. In this slide here, we explain this slide explain number one, they explain mechanism of action. As you agree with me with this one, what we have here for the angiotensin. Okay, on the left side we have list of medication used as ACE inhibitor. We have benazepril, captopril, enalapril, fosinopril, lisinopril, and other medication like kenapril. Okay, a case study now. Patient, Mr. Jones, 65-year-old male with a history of hypertension, type 2 diabetes, visit the clinic reporting persistent dry cough last several weeks. He has been on lisinopril for hypertension for the past year, and his current blood pressure 130/80, well controlled blood glucose, and glucose on metformin, and the patient is already on metformin. What is the probable reason of Mr. Jones' dry cough? What do you think? What is who is the offending agent now? Hypertension? Hypertension does not cause cough. Okay, diabetes? No. Metformin? No. Lisinopril? If you say yes, you are correct. And the reason, because lisinopril increased level of bradykinin. We already covered that in the lecture. Okay, what is the mechanism behind the dry cough associated with the ACE inhibitor? Increased level of bradykinin and substance B in the pulmonary tree. Decreased level of bradykinin substance B in the bronchial tree stimulates sympathetic system or inhibit parasympathetic system. If you choose A, you are correct. So increased level of bradykinin and substance B in the pulmonary tree. Okay, what is a compelling indication for use ACE inhibitors in patients with diabetes? Okay, dyslipidemia, coronary artery disease, diabetic nephropathy, peripheral vascular disease. So there is no direct effect between ACE inhibitor and dyslipidemia. No direct effect on the peripheral vascular resistance. It's not like a drug of choice. Here we can type here 3x. Here we have 1x question mark. Okay, this medication. Okay, yes, the most important one. Okay, the diabetic nephropathy. Compelling indication if the patient suffers from hypertension, for example, and diabetes. This is a medication we use it to protect diabetic nephropathy. Can we use it for coronary artery disease? Yes. So the correct answer here, the main correct answer will be this one here. But if someone chooses coronary artery disease, we will accept this answer because we can use it for the patient. For example, coronary artery disease plus diabetes, the hypertension plus diabetes for the main reason to protect the diabetic nephropathy. So the correct answer, the main correct answer here, and this one could be correct also. Okay, we're done with the ACE inhibitor. We discussed the medication list, how this medication works, major side effect, and compelling indications. Moving to the next group of medication used for hypertension, angiotensin 2 receptor blockers, ARBs. We have losartan, valsartan, candesartan. ARBs are competitive antagonists of the angiotensin 2 type 1 receptor, AT1 receptor. We are going to use ARBs, and this ARBs block the AT1 receptor. AT1 receptor work as similar to the ACE inhibitor with the effects. ARBs will be a substitute for patient who cannot tolerate ACE inhibitor. So if the patient cannot tolerate, This is the alternative. This group of medication also losartan, valsartan, candesartan block the secretion of aldosterone. This is very important issue here. ARBs does not increase level of bradykinin. Very important. No increased level of bradykinin, and there is a low risk of a cough or angioedema. Okay, so this medication to consider like first-line agent for the treatment of hypertension, especially in patients with the accompanying indications such as diabetes, heart failure, chronic kidney disease. Also, this medication considered like phytotoxic or like teratogenic and not allowed to use it during pregnancy. Valsartan, candesartan, losartan, and the suffix, we need to remember the suffix sartan. Okay, moving to the another group of medication, renin inhibitor, Aliskiren. Aliskiren selective renin inhibitors inhibit the renin available for the treatment of hypertension, should not be combined with the ACE inhibitor or ARBs. Okay, the same situation here. For example, when you say should not, because what we have the system renin, angiotensin, aldosterone system. So remember that we have renin. Okay, this will lead to the convert and formation of angiotensin 1, and then we have ACE lead to the angiotensin 2, then we have angiotensin 1 receptor. So this is maybe the pathway for the medication. So our medication here, Aliskiren, will inhibit renin. Okay, so the situation here, they said we should not combine with the ACE inhibitors. So we don't recommend to use it, for example, with the ACE inhibitor here. Okay, we don't recommend to use it with the ACE inhibitor or with ARBs. Why? So here we have one pathway. So this one pathway responsible for angiotensin pathway. If we inhibit any maybe steps in this pathway, there is no need to use another medication affect the same axis or the same pathway. So we don't recommend to use anything when you affect the same pathway. We prefer to use something like work with the different mechanism of action. So what we have here, they said should not be combined with the ACE inhibitor or ARBs, and now we understand, because this medication affects this one will be to deactivate this pathway. ACE inhibitor deactivate, ARBs will be deactivate. For this reason, we don't recommend to use combination between these three medications. Okay, maybe this will explain the similar situation when you have, I will speak about something else. For example, we have ampicillin for treatment of infections, and let me say the patient does not respond to the medications. It's not easy to type with the touch screen pen. Okay, but the patient does not respond. I tried to use another medication. So my suggestion, for example, I'm thinking about amoxicillin. I'm thinking about adding amoxicillin. Do you think this is correct? If you said this is not correct, not correct practice, you are right. It's not correct in practice, because both ampicillin and amoxicillin work on the same target. Okay, these medication work on the same target. Okay, this medication work on the cell membrane or on the cell wall of bacteria. The same target. Both medication work on the same target here. Now you can imagine here. Okay, this is a bacterial cell wall. you prescribe ampicillin, bind to the bacterial cell wall and inhibit, and then you decide to add amoxicillin, bind to the same. So there is no reason to add two antibiotic or two medication work on the same target. So what we have there is similar situation. We have two medication work on the same pathway. So we don't recommend patient or maybe using medication work on the same pathway. We can choose another group of medications. For example, we can choose diuretic. Will be great options for combined with the Aliskiren or with a renin inhibitor. Okay, now we have much drug with the drug class. So what we have here, we have a group of medications and the list of drugs. The first group, ACE inhibitor, ARBs, I will type S here, renin inhibitors. Renin inhibitor, we have only one medication. So I will start with losartan. What do you think losartan? A, B, C. Okay. Okay, if you said losartan is like ACE inhibitor, you are correct. Aliskiren. What do you think about Aliskiren? If you said renin inhibitor, you are correct. Candesartan, ARBs, lisinopril, ACE, captopril, ACE, candesartan, ARBs. Okay, so this is a situation here, how to select the correct, and here we need to remember the category or classification of medication already covered in our lecture. Okay, another case study, 59-year-old patient with non-Hispanic white ethnicity, seek treatment for hypertension. He has medical history of diabetes and hyperlipidemia. Now we have patient, 59, suffer from hypertension, diabetes, and hyperlipidemia. The current blood pressure, the reading 150/93. What is the suggested initial therapy for this patient? What do you think? Enalapril, hydralazine, verapamil, or metoprolol? If you said metoprolol, we talk about initial therapy. Or so when you start treat this patient, it's not the initial therapy. Verapamil, calcium channel blocker, not initial therapy. Hydralazine, no. The correct answer will be ACE inhibitor. So this is the correct answer, lisinopril or enalapril. Okay, we're done with the group of medication. I would like to summarize what we heard from the beginning until now. The first group of medication we discuss, for example, diuretic. We discuss with you beta blocker. We discuss ACE inhibitors. We discuss ARBs. And we discuss renin inhibitor. Now we have another group of medication called CCB, calcium channel blockers. Okay, for calcium channel blocker we have two group of medication. We have the calcium channel blocker group, subgroup. We have dihydropyridine and non-dihydropyridine. What we need to look on the brand name here and generic name. Generic name, we have amlodipine, phenoldiphine, nifedipine, and we have a list of medication. Then we have for the non-dihydropyridine, we have diltiazem, cardiazine. Then we have verapamil and another type of verapamil. So we have several type of medication belong. So what we need here, we need to remember only the medication name, and we focus on some medication. I will go with the highlight. Okay, amlodipine, nifedipine, diltiazem, and verapamil. This is what I need the student to remember in this case. Then we go for more details to discuss that later on. Okay. Moving to the how this medication works. This medication, CCB, calcium channel blocker, recommended first-line treatment option for black patient, African American. According to several studies, they found the African American patient, black patient, respond very well to the calcium channel blockers. They may also be useful in patients with the hypertensive, with diabetes, stable angina, and heart disease. High dose of short-acting calcium blockers should be avoided because of increased risk of myocardial infarction due to the excessive vasodilation and marked reflex stimulation. I'm not sure if I need to explain this situation here. This is a very important one. They said short-acting calcium channel blockers should be avoided. This one reminds me with the baroreflex. So you can see here we have amlodipine, nifadipine, diltiazem, verapamil. Okay, so for example, we have nifadipine, short-acting nifadipine. We don't prefer to use it because it may cause myocardial infarction due to the reflex cardiac stimulation. I believe I need to maybe go to the what we have there. Let me look on the screen again. Okay, I'll go to the whiteboard. They said we don't recommend to use short-acting nifadipine, short-acting, like regular one. This is nifadipine CCB, calcium channel blockers. They said we don't recommend to use it in patients with, for example, hypertension or angina or myocardial infarction. And we have the explanation why we don't recommend it. So we know that nifadipine block calcium channel in the peripheral vascular blood vessels. Okay, blocking calcium in the blood vessels will lead to the vasodilation. Okay, vasodilation will lead to the decreased high blood pressure. And if you go to the compensatory mechanism of hypertension, the result for the, if you talk about compensatory mechanism for hypertension, okay, if you look, go to the, so what we have here, we have nifadipine used for treatment, I will repeat it, for treatment of angina, hypertension, myocardial infarction, and we need to understand how the nifadipine works. This short-acting medication by blocking blood vessels, by blocking calcium channel in the blood vessels. Okay, this will lead to the vasodilation, and vasodilation decrease blood pressure. So as a compensatory mechanism, the result will be stimulate or increase heart rate. Increasing heart rate means increase oxygen demand. So if the patient suffer from angina or myocardial infarction, this will lead to the exacerbation and predispose to the angina or myocardial infarction. For this reason, we don't recommend to use short-acting calcium channel blockers in patient with short-acting in patient with myocardial infarction or angina. As we discussed, we have two groups of medication: nifadipine, amlodipine. We have non-dihydropyridine, verapamil, diltiazem. We need you to be aware about this group category here. Two medication from each: amlodipine, nifadipine, diltiazem, verapamil. Okay, verapamil, diltiazem, nifadipine. Then we have a group of medication. Also, we have phenoldiprine or philodipine here, estradipine, nicardipine, nizolidipine, amlodipine. A group of medication. This medication affect L-type calcium channels, but they found this medication does not calcium blocker does not block dilation veins. This medication mainly work on the arteries. Okay, so the question now, we can look on the what we have. diltiazem, they said diltiazem has favorable side effect of heart, so mainly affect the heart. Verapamil mainly affect the heart. Verapamil mainly affect the blood vessels. Here we need to remember also again, moving to our diagram. So we have a group of medication. We have verapamil, and then we have nifedipine, and in the middle we have diltiazem. Okay, here we can type here heart, here the blood vessels. So if we ask someone, for example here, what do you think, which medication mainly block, here we have CCBs. Which medication of calcium blocker will block the calcium channel in the heart? Verapamil. Which medication block calcium channel in the blood vessels? Nifedipine. Which medication considered like intermediate work on both intermediate action? We have diltiazem. So I hope this makes sense. This medication, because block calcium channel in the heart, the result will be decreased heart rate. For this reason, we use this medication for angina, for example. Okay, this medication will cause vasodilation. Okay, for this reason, we prefer to use this one for Raynaud's disease. Okay, for Raynaud's disease, or like peripheral artery disease. Okay, the diltiazem, we have another maybe clinical use. We are going to cover that later on. This medication could be used safely in patient CCB, calcium channel blocker, used safely in patient with suffer from asthma, diabetes. A question here: can we use a calcium channel blocker in patient with asthma and diabetes? The answer is yes, but there is no added benefit or value. Can we use it for patients suffer from peripheral vascular disease? Yes. So this is good, maybe good answer here for patients with hypertension plus asthma, or diabetes, or peripheral vascular disease. Speaking about the adverse effect, the main adverse effect: constipation, peripheral edema, and gingival hyperplasia with the nifedipine and amlodipine. So what we have here, we try to focus or maybe explain the side effect of this medication for CCB: constipation, common with the dose-dependent side effect, constipation, peripheral edema, and gingival hyperplasia associated with nifedipine and other dehydropyridine. Sorry. Okay, we have the list here for the medication again: amlodipine, nicardipine, nislodipine. For the non-dehydro, we have diltiazem, and we have verapamil, and we can go from there to look on which one is slow release or long acting. Okay, we have patient here, 45-year-old, report experiencing constipation. He was recently prescribed antihypertensive medication because elevated systolic blood pressure exceed the goal of more than 30 millimeter HJ. His current medication list compromises lisinopril, chlorthalidone, verapamil, rosuvastatin, and aspirin. What is the most probable factors contributing to his constipation? Chlorthalidone, verapamil. I will move this one. Chlorthalidone, verapamil, aspirin, or lisinopril. If you choose verapamil, you are correct. CCB. Okay, which of the following is recommended first-line therapy option for black patient with hypertension? ACE inhibitor, beta blocker, alpha blocker, or calcium channel blockers, CCBs. If you choose calcium channel blocker, you are correct. Okay, so this study, but maybe taken from the reference here, what they said here in the black patients, CCB and thiazide as monotherapy are more effective. So CCB option, thiazide another option, more effective at lowering blood pressure in black patient and should be used as first line therapy. Black patients have higher risk of angioedema, so please be careful, because when you prescribe ACE inhibitor, there is increased risk of angioedema compared with the white patients, and the angioedema could be life-threatening. Okay, so we're done with another group of medication we discussed now. We group of medication CCB, alpha blocker, α-ADRENOCEPTOR blockers. We have brazosine, doxazosine, terazosin, and you can see the name, brand name, Cardora, for example, Minibres, Hytrin for the medication, doxazosine, Cardora, brazosine, Minibres, terazosin, Hytrin. Okay, how this medication work? Block alpha-1 receptor, because here we need to remember alpha, we have alpha-1 and we have alpha-2 receptor. Okay, this will be covered in details with autonomic, will cover in details with autonomic nervous system, and I hope you may be familiar with this group of medication. So how this medication work? By blocking alpha-1 receptor, decrease peripheral resistance, lowering blood pressure, and cause relaxation, vasodilation for both arteries and venous smooth muscles. Okay, this medication will cause the lower blood pressure. The result will be tachycardia, reflex tachycardia, postural hypotension. Alpha blocker is no longer recommended as initial therapy. We don't prefer to use this medication as first line therapy. Okay, so we can use it sometime for patient not response to the traditional treatment. Another group of medication, we have a group of medication belong to the adrenergic system. We have labetalol, carvedilol. This group of medication block several receptors. You can see here block alpha-1, beta-1, and beta-2 receptor. 3 receptor, alpha-1, beta-1, beta-2 receptor. Carvedilol, this medication used for heart failure and hypertension. Labetalol, great medication for patients suffer from hypertension during pregnancy, and available IV for emergency treatment for hypertensive emergency. Okay, so alpha blocker, 3 medication, brazosine, doxazosine, terazosin. It's not in the clinical use as first line therapy. They carry the risk of postural hypotension. Moving to another group of medication that mixed by blocking alpha-1, beta-1, beta-2, labetalol, carvedilol for heart failure, labetalol for pregnancy with hypertension, and IV injection for emergency hypertension. Again, this is maybe we can cover it later on. Okay, moving to the next slide, we have 2 medication belong to the central acting adrenergic system. Here we talk about neurons. Okay, we're speaking about neurons, central acting. So we have clonidine, affect alpha-2 receptor agonist. That means clonidine stimulate alpha-2 receptor, work on the GI protein, and this will lead to the increase release of norepinephrine and activate sympathetic system. Okay, what do you think here? This one, GI mean inhibition, inhibit release of norepinephrine and inhibit maybe sympathetic nervous system, and for this reason decreasing blood pressure. Okay, reduce this medication reduce peripheral resistance and decrease blood pressure. Clonidine, primarily used for treatment hypertension. For patients not response to that 2 or 3 medication, we try to use clonidine. The clonidine not first drug of choice. This medication may cause sedation, constipation, rebound hypertension because it affects the central nervous system, We don't recommend to stop this medication suddenly. Methyl dopa alpha 2 agonist also. Methyl dopa convert to the methyl norepinephrine centrally, and I mentioned adrenergic flow from the central nervous system. Methyl dopa used for management of hypertension during pregnancy. Now we have two medication for pregnancy and hypertension. First one, methyl dopa, and the second one, labetalol. Okay, methyl dopa and labetalol for the hypertensive during pregnancy. We have some example here, mechanism of actions, some medication, nitroprusside, hydralazine. This medication work on the release of nitric oxide from the endothelium, affect calcium, verapamil, diltiazem, hyperpolarization, minoxidil diazoxide, and activation of dopamine receptor. We have phenoldopa. Vasodilation, we have two medication here. We have hydralazine and minoxidil. Here it's not in the first choice in that treatment, but we need to mention this medication because it's important for the literature review. This medication work directly on the smooth muscle, direct relaxation, primarily work on the arteries and arteries, decrease birth resistance, and decrease blood pressure. For this reason, this medication may cause reflex tachycardia. So remember, when you have decreased blood pressure, we discussed it in the beginning, this will maybe stimulate something called baroreflex. And I refer the student to go to the beginning of this lecture and watch the record for the baroreflex, what happened when you decrease blood pressure. Okay. When the patient suffers from tachycardia, the reflex tachycardia, this may cause angina, myocardial infarction, cardiac failure. For this reason, we don't recommend to use this medication in patients with these type of disease here. This medication may cause sodium and water retention due to the release of renin. Okay, we're done with this group of medication in general, and we have some maybe properties for each medication. Some characteristic. Hydralazine medication could be used during pregnancy. Now we have 3 medication. If I go back, okay, and I can add something here. Hydralazine, another group of medication during pregnancy. Okay, but hydralazine may carry the risk of lupus-like syndrome. So this one considered like reversible. When the patient stops the medication, the symptoms will be disappear. So which medication may cause lupus-like syndrome? Hydralazine. Minoxidil you consider like work on directly on the smooth muscle, cause hypertrichosis, which mean increase the growth of body hair, and this used now as topically to treat male pattern baldness. Okay, I will try to share the screen with you, just to be on the same page, me and you together. So you can see here the minoxidil hair loss treatment, and we have it like a solution. Okay, minoxidil here we can apply it to the hair, and this will enhance body hair. Okay. So hydralazine side effect lupus-like syndrome. Minoxidil may cause hypertrichosis. Okay, Patient brought to the emergency department with intensive tachycardia following a drug overdose. His family report that he has been depressed about his hypertension. Among the following drug, which of the following drug may lead to the dose-dependent increased heart rate? Captopril, hydrochlorothiazide, losartan, verapamil, minoxidil, because minoxidil causes vasodilation, and this will lead to the decreased blood pressure, activate or stimulate baroreflex, and the end result will be increased heart rate. Okay, emergency hypertension or hypertensive emergency, rare but life-threatening conditions. They said if you measure blood pressure and systolic blood pressure was 180 or diastolic blood pressure more than 120 with the target organ damage. For example, the patient comes with a history of stroke or the current stroke, myocardial infarction, and the blood pressure 180 or the diastolic blood pressure 120. This one considered like emergency treatment. This medication need maybe emergency treatment. We don't delay for the treatment. That's great. We go with the same numbers here. The blood pressure rises severely, but we don't have any target organ damage. We call this one hypertensive urgency. So we have here different approach. We have hypertensive emergency, we have hypertensive urgency according to the patient situation. If the patient suffers from stroke, myocardial infarction, and other cases, we call the emergency. If everything normal, only blood pressure high, severe high, we call hypertensive urgency. Okay, variety of medication used for hypertensive emergency. Most of these medication IV, intravenous injection, or could be infusion. Okay, nicardipine, clofidipine, nitroprusside, nitroglycerin, phentolamine, esmolol, labetalol, hydralazine, phenoldipan, and elabrelate. All these medications available for injection. Okay, now we move to the another topics about hypertension. If the patient suffers from resistance hypertension, for example, this one may be characterized by persistently elevated blood pressure level, even with that when you treat your patient with a 3 medication combination therapy, include diuretic. So the patient already on 3 medication, but blood pressure remain high. So the blood pressure persistently high, in spite of the patient on 3 medication already include diuretic. We have several explanations, several reasons. The patient could be inadequate adherence, the patient on excessive alcohol, or the patients are from another concurrent conditions or concurrent use of some medication that increase blood pressure, or the dose is not enough, or the patient have maybe used drug with a similar mechanism of action. We don't prefer to use medication with a similar mechanism of action. Okay. Here we need to focus a little bit about genetic, what that means for us. If you take, for example, if you take 100 patients, those patients suffer from hypertension, and you prescribe lisinopril, or let me say enalapril, 10 milligram per day or twice daily to the patient. Okay, you are going to have different response according to the genetic response. So when you have 100 patients suffer from hypertension, you prescribe enalapril 10 milligram, that you are going to have different response. Let me say the first one decreased blood pressure by 5%, another one 1%, that's 3%, 10%. So you have different response towards enalapril. And they said this one related to the pharmacogenetic of antihypertensive medication. We have variation in single genes that maybe response to for the effect of antihypertensive medication. One example here, polymorphism and the cytochrome 2d6 gene encoding cytochrome 450 family member that responsible for phase 1 metabolism, and this medication responsible for variation of beta blocker metabolism. So if the patient have any defect or any maybe abnormality in this gene 2D6, the response towards beta blocker will be not the same as normal person. Okay, moving to the next one. If the patient, for example, have decreased acetylation, and this acetylation, this process responsible for metabolism of hydralazine. For this reason, the patient may decrease or increase metabolism of hydralazine. The same situation for catechol transferase. This enzyme responsible for metabolism of methyl dopa will be applied. Sulfotransferase, this enzyme responsible for metabolism of minoxidil. Okay, any change in these enzymes, any change in 2D6, acetylation, COMT, methyltransferase, or sulfotransferase will affect this medication. That's important. So when you have case, the patient have abnormality in 2D6 gene, which drug will be affected? Beta blocker. N-acetyl acetylation decrease, which drug will be affected? Hydralazine, so and so on. Okay, patient has genetic polymorphism, cannot rapidly metabolize drugs. For acetylation, you would be most concerned about polymorphism if the patient taken which drug. So here the patient talk about acetylation, genetic defect, sotalol, clonidine, nitroglycerin, prazosin. What do you think about hydralazine? Yes, this may be a phase of metabolism responsible for hydralazine metabolism. Okay, here we have 59-year-old, suffer from hypercholesteremia, diabetes, hypertension, come to the clinic for follow-up visit 3 weeks after the starting new medication. Okay, now the blood work done, and the blood results show the potassium level 4.8. Okay, potassium increased, potassium level from 4.8 to the 5.2. So what we have here, we have increased potassium level. We talk about blood here. And the increased creatinine level. Administration which of the following drug is the most responsible for the change in this patient renal function? Okay, prazosin. So we talk maybe which medication affect potassium level? Metformin, furosemide, hydrochlorothiazide. This will lead to the decreased potassium. Diuretic decreased potassium in the blood. Atorvastatin, metoprolol, lisinopril, increased level of potassium. This is the correct answer. So what we have here, we have 2 slides for combinations. We have some slide with the 3 drugs in one tablet, for example. Okay, in this case, we are going to conclude our lecture. I hope you enjoy our lecture today about antihypertensive medications, and our next lecture will be focusing on diuretic, and we are going to have more details about diuretic, and diuretic is like the most important medications for the hypertensive and heart failure. Also, we have some diuretic used for motion sickness, other diuretic used for glaucoma. So we are going to speak about diuretic in the next lectures. And as you can see in this lecture related to the diuretic, this lecture also related to the heart failure, this lecture also connected with the diabetes, with the angina, myocardial infarctions. So we have a lot of connection between hypertension and other cardiovascular disease. And thanks so much, and see you again.